Okay, just like what I said previously, if you find that my English is difficult to be understood, just open your mic and then just ask me to repeat your what I tell you. So help me to help you. Okay, thank you so much. Okay, so let's pray first. In the name of the Father and of the Son and of the Holy Spirit. Amen. May the Holy Triune God live and reign in our hearts and in the hearts of all people. Amen. May the darkness of sin and the night of unbelief vanish before the light of the Word and the Spirit of grace. May the heart of Jesus live in the hearts of all people. Amen. In the name of the Father and of the Son and of the Holy Spirit. Amen. So we have heard about drug utilization research, and actually there are some names, some synonyms for this type of research. So, but yeah, in this session, I will call it as drug utilization research. You may probably heard about drug utilization review, drug use evaluation, drug utilization evaluation, and also medicine, uh, medication utilization research, medication utilization evaluation, and so on. I think although some of them may define their terms by themselves, some experts in that field, but to some extent they have kind of similarities, big similarities to each other. Okay, so there are some definitions then that I will uh, uh, I will read it for you with the definition, and then we try to find the similarities between those definitions. So drug utilization research uh, defined in the book of drug utilization research methods and applications as an eclectic collection of descriptive and analytical methods for the quantification, the understanding, and the evaluation of the processes of prescribing, dispensing, consumption of medicines, and for testing of interventions to enhance the quality of this process. So, in this definition, the drug utilization research is seen to be conducted to all process of the drug from prescribing and then to dispensing as well as to the consumption or to medication taking by the patients, and how to optimize this process. So it can be descriptive, it can be analytical as well. So uh, in this definition, in this long definition of drug utilization research, it can be seen that drug utilization research do not do not is not related to the manufacturing, to the distribution of drug, to the to retail pharmacy, but from prescribing, the pattern of prescribing, and then the dispensing and consumption. So, so that just, I think, although it is long, but it's quite, yeah, they have the scope uh, to introduce the drug utilization. Another definitions is broader by the WHO expert committee. This is the marketing, so the advertising and so on, and also the the medical representative approach to the physicians are also a part of the drug utilization research. So marketing, distribution, prescription, and use of drugs in a society. So it is broad, with special emphasis on the resulting medical. So the consequences is not just being viewed from the perspective in health, but also in social and economic. So yeah, so this definition is broader than the definition before. And then, as what I said in the beginning, that there is another there are some synonyms, and one of them is the drug utilization review or drug use evaluations. It is used mainly in the US. So if you got a reference from the US, then usually they call it as the drug utilization review or drug use evaluation. It is an authorized, structured, ongoing review of prescribing, dispensing, and use of medication. So, uh, this can be said as well as the quality assurance measure. So, this definition is quite similar to the first definition, the long definition, that it uh, may not involve the marketing and the distribution of the medications. So yeah, so all definitions, the similarities between all definitions recognize, all of them recognize the non-clinical factors, including the socio-anthropological factors, such as in our society, probably the sharing of medications are common, especially in the same family in the same house, under the same roof, or even in the neighborhood. When even in the friendships, if you have friend uh, that needs a drug, probably friends, university friends, they are not pharmacy students. They probably tell you that they have a kind of some health complaint, then they will ask you about something related to drugs then or medicines. Then you probably, if you have it, I think as an Asian, I will say that we will offer our medication to them. Although this practice is not really you know it's not uh, correct. I mean, because the complaints, the symptoms, the signs that our friend have are probably different with the history of our complaints, our uh, our experience. So yeah, but it happens because in our culture, I think you may disagree if you have a different culture, but in my understanding, we have a similar culture. So in my culture, for example, if someone comes to us and then we have something to offer to help them and then we hide it, it means that we are impolite. Okay. Do you agree to this? Right. So there is a phenomenon uh, for kind of the social use of medications or social use of drugs. So for sharing, so medication sharing. Okay, and then the behavioral factors. Sometimes people sometimes when patients receive antibiotics, well, it is a common knowledge. that when someone receives antibiotics, it means that they have to finish the antibiotics they have over the course of the treatment. But then, uh, because most of us feel like feel already healthy after taking some medications before it finished, then yeah, we have a leftover drugs, leftover antibiotics that can contribute to the global problem, which is the antimicrobial resistance. So yeah, the drug utilization research also cover this topic, this theme. And then the economic factors. As usually, we just like what happens, I believe happens broadly in our communities in Indonesia. We have, to a certain degree, we have kind of a belief to the use, to the the benefits of taking medication. So some of us probably, when we receive a prescription, we uh, you know we buy the prescriptions, yeah, and then we buy the medicines. Sorry, this is the economic factor. So we buy the medications, but not. We just bought half of the total prescribed doses. For example, a patient has got a prescription containing 10 tablets of uh, amoxicillin, then they probably just buy three because they feel that buying 10 is probably not, it is not affordable for them to buy 10, then they just buy three or five. Yeah, while yeah, then it also probably correlated with the behavior that I mentioned before, the behavioral factor that after taking three or five, they probably will feel okay, and they stop the treatment. And then, uh, so all definitions also uh, point out the level of effects of drug utilization from individual to the society. So the drug utilization methods, sorry, the drug utilization review may, yeah, may explore the drug use, the medicines use from individual to the population, to populations. So we have, uh, you know, a big picture of how a particular drug is used in our society. It is said that this type of study is a bridge between pharmacoepidemiology and health service research. So the drug utilization research can be said, some of them are part of pharmacoepidemiology, uh, and some of them can be health service research. So nowadays there are a lot of research topics that are interconnected, and sometimes just like you know quite similar to each other. And sometimes I'm confused about that as well. So bear with me. And yeah, some drug utilization studies said to be a bridge because between these topics, because some of the study put a strong focus on health policy. So it is related to, for example, now we know about the antibiotic stop order. So if a patient receive an antibiotic in when during his or her admission to a hospital, then during 48 to 70, 72 hours, they can receive the antibiotics. But when there is about the no update about the clinical data of the patients, usually the laboratory data that confirms that patients need the antibiotics, then the pharmacists in the hospital uh, can stop the administrations of antibiotics to the patient. So it needs the policy and the management level in the hospital uh, to be sure. And then it is said to be closely connected to clinical pharmacology if the focus is on facilitating the safe and effective use of medicines in populations. Usually the clinical pharmacology focusing in the smaller populations, while in pharmacoepidemiology, the drug utilization research can be a broader population. So there are four clinical problems addressed by this drug utilization research. So the first is the extent and pattern, the second is the quality, and then the determinants and the outcomes of drugs exposures. So if you want uh, to conduct a research in this topic, it is, I mean, for me, it is very doable. It is very feasible because there are a lot of themes, a lot of topics that you can get from this this type of the domains of the problems, the types of problems in drug utilization research. Let's see one by one. So drug utilization research can study the extent and the pattern of drug exposure. So we want to know for a particular drug, for example, the corticosteroid. Uh, Corticosteroid can be used for many uh, complaints, many conditions such as inflammation, and then allergy, uh, even for you know for to some extent for analgesics. So they probably they in the same in the different population in different community in different geographic areas, they are used in different ways for I believe that they have the same purpose. Some of the purpose are similar, but some probably different. Just like what I found here in Australia when I start my PhD, I learned that uh, corticosteroids are not being prescribed intensively in Australia, but in my country, my home country, Indonesia, it is prescribed heavily. So if you are a pharmacist in Indonesia, then you can easily find that this person receive corticosteroid, that person, that patients during a day you can find many uh, prescriptions on corticosteroids. So yeah, so the profiles and the trends of drug use, and so even some drugs we can search some drugs in the developing uh, developed world, some drugs are not being used or they already recalled or withdrawn from the market. But in some countries, they are still used, such as in Indonesia. We have a lot of drugs that are not being used anymore in some uh, developed countries. So, yeah, if you want if you want to know what kind of drugs that are not that are still being used in the Philippines, you can search it and it it can become your research topic. And then the incidence, prevalence, and trends over time, whether even in the same drug classes, for example, in the statins use, probably the prevalence of the use of uh, statins, different types of statins, difference over time. And we can also uh, try to find the difference between one region to the other regions. Probably the use of antibiotics are more intensive in in the city, while, but it's not extensive in the rural area, something like that. So we can study the extent and pattern of drug exposure or drug use in the society using this drug utilization review. And then the second one is the quality. This quality. Um, we know that we have a big problem in Asia that uh, some of the medications that are in our market are counterfeit. So either counterfeit, either counterfeit or having a low quality. So it is a big problem in our society in Asia. So the quality, it is one of the quality factors, but there are a lot of uh, quality. Uh, the topics are the factors related to quality that you can study. For example, the choice of drug. Yeah, the choice of drug. If can we can study the prescriber's choice of drugs and the reason why they choose this over this, and we can compare it with the guidelines and so on. And also we can compare with the standard from the the insurance company. And then cost, drug dosage, yeah, dosage, how to stop, for example, how to stop the corticosteroids. It should not be stopped. It must not be stopped. It must not stop directly, abruptly, but it must use tapering off method. So by reducing the the dose over time for 2 weeks. And then drug dose awareness of drug interactions and adverse drug reactions. And in my society in Indonesia, in Indonesian communities, I believe that many people who have chronic diseases will try at least not only these modern medicines but also traditional and complementary medicine. So sometimes they mixed up. There are mixed up of medication that they have, while it probably raises the hopes of being, uh, you know, treated or being healed. But at the same time, it will increase the risk of drug interactions or adverse reactions. So we remember that drug interactions is also part of adverse drug reactions. Okay, and then the proportions of patients which are aware or unaware of the costs and benefits of that treatment. Okay. Then the determinants of the drugs exposure can be from the user or the patient's characteristics, the prescriber characteristics, and also the drug characteristic, the drug itself, characteristics of the drug itself. And then the prescribing decision, yeah, can be influenced by many things: advertising colleges, working circumstances, seniority, yeah, many things. And then, yeah, you can read about the Hofstadter's model to learn about the cultural factors such as the power distance, individualism, masculinity, uncertainty, avoidance, and long-term orientations. Okay, and the last one is the outcomes of drug exposure. So by the outcomes, then we back to the definition of the pharmacoepidemiology, that it studies the effects of drugs. So yeah, it has drugs may have good and also bad effects. So the bad effects itself, we can call it as study of pharmacovigilance. So yeah, in the US, it is estimated that adverse events account for 28% of emergency department visit, 25% of ambulatory care encounters, and 70% of those visits are preventable. In if I personally, I'm always amazed if someone can estimate something like this using the numbers, because I imagine that when I imagine if I study to estimate something in Indonesia, it will be very difficult, because adverse events are usually not being recognized in developing world. People may blame the use of drugs. They may know the adverse effects, but it is uh, rare to find patients come to the hospital and then complains about that the current conditions are caused by the drug consumption. Yeah. So yeah, it is very difficult. So when there is a percentage like this, really I'm really amazed. Yes. And then the other factors influencing drug related admissions is the wrong indication, potentially toxic drug, and the excessive number of drugs, also excessive dose. I remember a story from my colleague in the Philippines. If you know Mom Elizabeth, one of your lecturer that is now studying PhD. She told me that a long time ago, I think, she told me that uh, she got a message from a friend who worked in a hospital, so a hospital pharmacist, that there was a patient, a young patient, I forgot whether it is baby or not, that are being hospitalized because of overdose. It is because the parents do not understand how to administer the drug. The instruction was actually to give only you know the teaspoon of syrup. Oh no, sorry, uh, sorry, tablespoon syrup. So 15 milliliters of syrup to the patients 3 times a day. So, but the parents, the parents, uh, what the parents understood is that they have to give it 3 times a day, but they can give it at once. So they give three tablespoons of syrups to their, their kid, and then yeah, the kid is being hospitalized. So yeah, something like this. The this is caused by you know miscommunication, for example, and yeah, and it can be studied using the drug utilization study. So, to some extent, we study the bad effects of drugs to prevent these bad effects to occur in the future. So that's all about the themes or the clinical problems addressed by drug utilization research. Four. The first is the extent and also the pattern. Yeah, we can see the pattern in timely manner, time by using a timeline, different periods of years. We can see the pattern from the different locations of the research sites. And also the second one is the determinants, and then the quality, the determinants, and the last one is the outcomes. So many topics are being generated from these big themes. Yeah. So how to do it? Some of the measurements used to study the drug utilization research are in this slide. The defined daily dose, triple D, and then prescribed daily dose, and for antimicrobial days of therapy. Actually, there are a lot of measurements that you can find to measure drug utilization study, but uh, I just introduced three of them. For Have you heard about the defined daily dose before? Hello? No? So the defined daily dose is not the actual dose that should be given to the patient, to each patient to maintain, to have a specific treatment. So this is uh, a dose that is calculated from a certain population. It can be a population of a country, can be a population of a region, of a city, and even of uh, patients in a hospital. So yeah, that is the defined daily dose. So the defined daily dose is a gross measure to understand how frequent or how um, massive a drug is being prescribed to the patients, not being prescribed, but received by the patients. So we can then when we have this the measure of this defined daily dose, we can use it as a standard of measure to compare one health facilities to the others, or one region, one area to another area. So, for example, if we have the amoxicillin defined daily dose in hospital A is, let's say, 7, then in the hospital B, 10 for the same antibiotics, then we can say that the antibiotics is used, uh, more intensive in it's used more intensively in hospital B than hospital A, something like that. So it is just a drug statistic. So we cannot use this defined daily dose to be our reference range to, uh, you know, to inform the doctor, the physician, inform the patients about the dose that they have to receive. Okay, this defined daily dose is developed historically, yeah, developed by the WHO Collaborating Center for Drug Statistics Methodology. So you can access the methods, yeah, and the explanation about the methods in this website, the WHOCC.no. It is in Norway. I will introduce the website to you, and in this defined daily dose, they use what is called as the ATC. Yeah, ATC is the anatomical, therapeutic, chemical classification system. So ATC. They use the ATC. So this is the website. So they let me show you the ATC. So the ATC is actually a systematic coding, systematic classification of every chemicals that have therapeutic properties. So we are grateful that some experts already work in this, because there are a lot of known medications today. So use, let's say we want to see amoxicillin. Let's search for amoxicillin, and then let us know what kind of the ATC code for amoxicillin. So for amoxicillin, we have so many codes. We have J01CA04, as well as we have J01CR02, as well as A02. So we have J and A, so we have a lot of different amoxicillin. So for J01CA04, amoxicillin is in the single form, while the others in the others code, they are in the, in the combination with other drugs. So for this one is the for the J is for infection, for the class of infections, anti-infections, anti-infective agents. This one is with the beta lactamase inhibitors, and for this A, they are used for gastrointestinal purpose complaint. So for this one, so you can learn as well pharmacology from ATC. So this is actually amoxicillins are combined with uh, proton pump inhibitors, as well as other antibiotics, mostly the clarithromycins or metronidazole, as well as levofloxacin. So they are from macrolides, and except the metronidazole. So they are used to treat the infection of Helicobacter pylori in the gut. So it is to, uh, you know to treat the peptic ulcer disease. Even there are some four combinations. Usually the three combinations are the best. So let's see amoxicillin. So see here J, sorry, amoxicillin is J01 is J is anti-infectives for systemic use. J01 is antibacterial for systemic use. J01C is beta-lactam antibacterials, penicillins from the family of penicillins. And J01CA is penicillin with extended spectrum. And the amoxicillins are in number 4, the amoxicillin. So it has the ATC code is this one. Then they have the defined daily dose 1.5 grams for oral and 3 grams for P. P is for uh, P is for parenteral. Yeah, for parenteral, 3 grams. So amoxicillin is here. Let's see what other penicillins with extended spectrum in J01CA. So we have ampicillin, rifampicillin, carpicillin, amoxicillin, and so amoxicillin. This one we have it, and then there are a lot of new cillin, piperazine, ticagrelor, and the old beta-lactam penicillin, ampicillin. Some of them I haven't heard. Yeah, hetacillin, I just heard it. Yes. So let's see another code for amoxicillin. For example, this one. This is with beta-lactamase inhibitor. So this is what is it? Hmm, so I can use this one, sulbactam and ampicillin. Hmm, okay, anticonvulsants of beta-lactam, sultamicillin, piperacillin, and beta-lactamase inhibitors. Yeah, usually we call it as coamoxiclav for amoxicillin with the beta-lactamase inhibitor. And then this one is in the combinations for eradications of this one. Yes, so in ATC-DDT method, sorry, here we will use, we will define what kind of uh, medicines that we will study, and then we will restrict which code that we use. So yeah, this definition I already told you. There are some formula to calculate the TTTs. So it is not just a single formula. You can say in the website that I presented to you. So it can be drug defined readers can be used for the ambulatory drug use. Can be used as well for the in the hospital setting. So you you may see that the you know the measure is different. This one is DDTs per 1,000 inhabitants per day, while this one in the hospital setting is DDTs per 100 bed days. So in these bed days, it means that if a patient is in the hospital for 5 days, then it can be said as 5 bed days. So the number of patients multiplied by the number of occupied beds, then we can have the bed days. And then occupied bed per day, yeah, per day. We have that. So the population in bed days. And then using outpatients, we can use DDTs per inhabitant per year. Yeah. And then another method is not using the defined daily dose, but prescribed daily dose. So this is PDD is using the prescription. So it is the average daily dose prescribed as obtained from a representative sample of prescriptions, but it has limitations that it is lack of clear and exact dosage indications in the prescription, as is often with the case of prescribing with prescribing of insulin. Uh, Patients that receives insulins may have different dose of insulin depending on what stage of the diabetes status. Yeah, so mm, there is another one. There's another one. This days of therapy method. We can combine the days of therapy with uh, triple D, the defined daily dose, if we studied defined daily dose for antibiotics. Yeah, so days of therapy are the length or the number of days when at least one dose of medication was administered. Yeah, yes, it's just on route of administration. So in the hospital, usually the patients receive antibiotics. In the beginning, they will receive, usually they receive the IV dose, so the parenteral dose, and then if they their condition got better, then they will be switched. The antibiotics will be switched to the oral dosage forms. So it will change. Or if the antibiotics do not have its oral equivalent in in solid dosage form or in oral dosage form, then they will change find the suitable ones to change it. At least they will switch from IV to oral, yeah, because the conditions is going better, then they do not need to receive the IV or parenteral route anymore. So either they receive the the parenteral route or the oral route, it doesn't matter. We count the days where they use the antibiotics. So yeah, so I already explained this, and yeah, in drug utilization study, because we want to conduct a study that its results can be comparable to other studies or for the future studies, then we usually use this standard classification system. So I already introduced the anatomic therapeutic chemical classification system, the ATC, and then we have also the international classification of diseases. So if we want to just narrow our research to a certain disease, then we can define the disease using the ICD. While in Indonesia, I learned that a lot of hospitals already adopt in their system, already adopt the ICD in their system. So I mean, if a patient come to that hospital, then the diagnosis in the system will also include the code from the ICD. For example, for the the gastric, the peptic ulcer disease may be coded as J something and so on. So it has a similar. So if we track down the disease, then we can find a lot of patients using the similar diagnosis. Uh, yeah, yeah, I hope you understand. Then we have another more category. It is the systematic, systematized nomenclature of medicines that provides a core general terminology for use in various medical fields. So yes, it's nomenclature of medicines. So I think that's all that I can give to you. And actually, um, for me to study about pharmacoepidemiology, I mostly learn about the drug utilization research. So I learned this and then I understand the pharmacoepidemiology. Is there any questions? I think I will stop my presentation here. I'll stop my recording. Okay, if there is no questions, then thank you for coming. I will end this Zoom meeting, and do not forget to check the your canvas, because I give you was it an assignment, a group assignment, group of 3, that must be submitted on next week on 14th of May. Okay, don't forget to do that. Okay, see you in the final exam, and I hope you can study. Just feel free to send me an email if you want to ask questions related to the materials that I delivered to you. But use the University of Jember email, the anton.pharmacy@ac.id. Find it in my slide. Thank you so much. Thank you for coming, and see you next week.
Thank you,
See you.
sir. Bye-bye.
Thank you,
Thank
sir.
you,
Have a nice
sir.
day.
Thank you, sir.
Thank you, sir.
Thank you, sir.